My name is Aneesha and this is Amar, and we're both clinical fellows in acute medicine at the Western General Hospital in NHS Lothian. And we also have our consultant, Dr. Sutherland here, who is an acute medicine consultant and the SDEC lead. Today, we would like to share our findings from trialling point-of-care D-dimer testing for venous thromboembolism referrals we see in the same-day emergency care unit. Next slide, please. Thank you. So our VTE referrals make up more than a third of our patient population seen in SDEC. The patient journey starts at triage, at which point they have their bloods drawn, including lab-based D-dimer, median turnaround times for which have been over an hour and a half. We currently have a fixed number of slots, scanning slots available every day, and patients requiring scans are booked in to the next available slot, usually within the next couple of days, and they are anticoagulated in the interim. Next slide, please. Thank you. So Lumira DX is a company that offers point-of-care testing for a variety of markers, including D-dimers. Their point-of-care D-dimer test is carried out by drawing capillary blood, similar to BMs, with the results available in just about 6 minutes. Now, carrying out D-dimer testing such that results are available at the time of clinical assessment can risk introducing a bias, whereas lab testing, only if indicated by clinical assessment, can lead to longer waiting times and poor patient experience. But this could potentially be resolved by the use of point-of-care testing with quicker turnaround times. Next slide, please. Thank you. We have carried out this project in 2 phases so far. Phase 1 was aimed at evaluating accuracy and safety of the Lumira point-of-care test, D-dimer test, against VIDAS, which is the gold standard. Our focus in phase 2 was to evaluate the impact of change in the process. This will become clearer in the next slide about the methods. Next slide, please. Thank you. In phase 1, we collected data for 187 venous thromboembolism referrals seen in October last year, when we carried out both lab-based and Lumira point-of-care D-dimer test at the time of triage. The results were available at the time of clinical assessment and were used to make decisions about scans only for DVT referrals, but not for PE referrals, where we just collected the data and recorded the results for our analyses. In contrast, in phase 2, we collected data for 140 venous thromboembolism referrals who had the point-of-care D-dimer test done only if indicated by clinical assessment, and lab D-dimer add-ons were requested and followed up later. We used point-of-care results to make scan decisions for both DVT and PE referrals in this case. Next slide, please.
So moving on to the results. First, we looked closely into whether the point-of-care test was safe, comparing it to the lab-based test. Okay, so that's the main purpose of phase 1. And really, we were asking whether the 2 tests agree. And indeed, in almost 90% of cases, the 2 tests give the same answer. So positive or negative for D-dimer. In a small minority of cases, there's a disagreement between the tests, so with discordant results. And in that, where they disagree, the point-of-care test has a tendency to be a little bit more positive. Now, we know the point-of-care test has a greater variability of results, and our impression was that the threshold suggested by Lumira might be a little bit lower to manage this variability. So sacrificing some specificity to keep up a good sensitivity. It's important to note that in cases where the 2 tests differed, so for example, we can see there was 3 so-called false negatives where the point-of-care test was negative, but the lab test was positive. In these discordant cases, there was no patients with a proven venous thromboembolism. So this is encouraging to suggest that the point-of-care test is safe insofar as we're not missing VTE that could have been picked up using a lab test, albeit with the caveat that it's got a slight tendency to be more positive. So next slide, please. And looking at phase 2, which is where we began to use to change our processes, to use the test in a targeted fashion, we can see the results are consistent. So again, the two assays match fairly closely. Next slide, please. But what is the actual impact on the way the department ran? So if we compare weeks that we were doing our classical indiscriminate testing using the lab-based test to weeks where we were doing our new targeted point of care facilitated procedure, there was no significant difference in scan rates comparing groups with the chi-scared test. So despite the slightly increased tendency to being positive with the point of care test, we didn't see an increase in scans. But also, despite removing our bias for pre-assessment D-dimer, we've not seen a decrease in scans either. So it's been generally similar. So I mean, from this, we could say that the point of care test is safe insofar it's similar to the lab test, and it could be useful, especially if deployed in a different way going forward. And that could focus on, for example, reducing patient time in department. So next slide, please.
Thank you. So as seen in the results slides, our analysis showed encouraging outcomes regarding accuracy and safety of the Lumira point of care D-dimer test. As we have seen, there is a higher degree of false positives due to the lower specificity. However, as found on the chi-square testing, there wasn't a significant change in the number of scans being carried out as a result. We also looked further into the discordant results, as just discussed, where VITAS and Lumira didn't agree. And it is pertinent to highlight that in none of the cases was a venous thromboembolism related pathology found on scans, where Lumira was negative, but the lab-based D-dimer was positive. The sample size of discordant results is quite small to be completely confident, but this will continue to be closely monitored in addition to our accuracy measures. Now, it was noted also that despite these encouraging results, there was a lack of confidence across the team for changing clinical protocol to basing decisions on point of care results. We also noted a need for standardized approach across the team, including ensuring that D-dimer is used appropriately and only when required, which will be addressed by internal training sessions. The next phase also includes embedding point of care test into service change, streamlining the DVT pathway with integrated, customized electronic patient record functionality, and will also involve looking at whether carrying out point of care D-dimer testing reduce time to scans and reduce waiting times in the department. Thank you for your time.